Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer.
Hey everyone, welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon, here about a special episode on what do my scans mean, interpreting scans that you're having after incidental findings or screening scans. And I'm here joined with Heidi Onda and Lauren Groner. Maybe you both could introduce yourselves.
Yes, I'm Heidi Onda. I am a almost 7-year survivor of stage 3A lung cancer. And I co-founded the White Ribbon Project with my husband, Pierre, to increase the awareness of lung cancer.
That's hard to follow up. But I am Lauren Groner. I am a cardiothoracic radiologist. That means I am a radiologist who looks at images of the heart and the lungs. That's my specialty. And I'm a health services researcher. My research focuses on trying to improve the uptake of lung cancer screening among people who are eligible. And I'm delighted to be here.
Yeah, I couldn't pick two better people to be joining today as we're going through what scans are, how to interpret them, how you should feel about them, some of the problems with our scanning systems. Heidi is someone who was diagnosed with lung cancer and something you weren't really expecting to find. You're someone who could speak well to the issue of scanxiety, as we call it. So maybe in your own words, could you describe what scanxiety means?
The scanxiety for me is, the anticipation of waiting, number one, for the scan to take place, but more importantly, what is the result of that scan? And the waiting can be just excruciatingly painful. My mind would sometimes just go to overdrive of the what ifs, like what if this, what if that, and then what are next steps. So those results, dictate what your continued path is treatment-wise, but also an emotional roller coaster on how do you want to navigate your life. So scans are super important.
Yeah. And I mean, from a patient perspective, you get scans in lung cancer, we get them all the time, and other cancers. It's really a cornerstone of how we evaluate how the cancer process is going. And Lauren, you built a pretty strong career on interpreting scans in cancer as well. So can we speak a little bit to why scans matter so much in oncology?
Yeah, that's a really good question. I think, of course, I believe that imaging is important because I want to find meaning in my own work. But I think if I'm really trying to kind of hammer this point into a broader audience, we can think about scanning as being important in cancer prevention and control, treatment, and monitoring. So there are a few imaging-based cancer screenings that we have. So one is low-dose computed tomography that screens for lung cancer screening. Of course, everybody knows about mammography for breast cancer screening. And then more recently, CT colonography was approved for colorectal cancer screening. What's really important about cancer screening is that it looks for cancer before you have symptoms. And that is the whole idea, that we find cancer when it's at an early stage, before symptoms develop, when it's easiest to treat and even potentially cure in the case of some lung cancers. So that's why a lot of my work is focused on that. But even after that, you go to the doctor, you find a lump or, whether it's in your breast or your neck, your thyroid, whatever that might be. And so imaging can kind of help tease out what that is. Is that cancer? Is it something else? Maybe you're just tired or maybe you have a cough. Imaging is really helpful for kind of further investigating the etiology of those signs and symptoms. And then, of course, when someone is diagnosed with cancer, imaging is crucial in terms of what we call staging. So what that means is that as a radiologist, I'm looking at images, I'm measuring the tumor size, right? And I'm seeing, has it spread to lymph nodes or has it spread, even further to other sites? Because your treatment regimen largely is based on the stage of your cancer. And then, of course, we use imaging to monitor your response to treatment. Are you responding to the treatment that your doctor put you on, or do they need to try something else? Like, is it working or is it not? And so I think imaging is sort of critical in all of those components of the oncology continuum.
Yeah, and building on that, in lung cancer and other cancers, we use other things to evaluate how someone's doing. We have biomarkers, we use blood tests, and those things change over time. And, what we always do if something looks concerning is we'll say, oh, we're going to get a scan. So pretty much all of what we do is foundational on what we're seeing on the scan. So I think it's really important that when someone gets that scan, which is now directly sent to them before going through the physician filter, I think it's really important that people understand why these things are ordered the way they are, what the different terms mean. So hopefully we can provide some clarity today. Maybe we can kick off just, what are the different types of scans that one might get?
Yeah, question. So the ones we see most commonly, obviously there are a lot of types of imaging modalities, and it could take an entire episode, but I'll just kind of hone in on the most important ones. So are the ones we see most commonly. So of course, everyone knows, or most people know what a CAT scan is, right? A CT. So this is an imaging modality that uses X-rays really to create what are essentially different angles of your body to create a three-dimensional picture. Really good at looking at the lungs, looking at the liver, other solid organs, the bladder, that sort of thing. It's the test that we use most often in terms of staging and kind of monitoring response to treatment. So another modality that we use commonly are PET CTs or PET MRIs. So this would use a drug that you inject called a radiotracer, and usually that mimics something that would be active in your body. So for example, one of the most common types of PET scans that we do are FDG PETs, and FDG is glucose mimic. So that's the sugar that your body uses for energy. And not everything that lights up, quote unquote, with, this radiotracer is cancer, because our muscles use energy and glucose all the time. Our brain uses glucose to function. But typically, because cancer cells are metabolically active, that will light up on a PET scan. And there are actually other PET CTs and radiotracers that bind directly to different kinds of cancer cells. So one example is like a PSMA PET for prostate cancer, or dotatate PET for neuroendocrine tumors. And then I would say the last scan that we use quite commonly in terms of further investigating with staging or monitoring would be MRI. So magnetic resonance imaging, which really uses a magnetic field to create really quite pristine images of the body that offers really impressive contrast. It's really good for, let's say, prostate cancer. And it's good for looking at soft tissues, at some primary bone lesions. It's great for liver, pancreas, that sort of thing.
Well, and notably, I didn't just what we call plain film, where it's just like you snap the thing. And so why would you not incorporate that into this list?
Yeah, so sometimes we do. And I see chest x-rays used for certain kinds of cancer, sometimes with people getting monitored for testicular cancer. They typically are younger, for example. The problem with chest x-rays is that if you're looking for metastases, right, spread of the tumor, those can be very small. And so you don't want to miss something like that. And so something like an MRI, a CT, or a PET scan just gives you, so much more information, so much more detail compared to, an X-ray.
Yeah, that makes sense, right? I've seen a lot of people who have an X-ray and there's something that's, we would say, missed on the X-ray, but it's hard. Like X-rays don't have great resolution. So we use these other tests a lot. In lung cancer, I would never make strong recommendations based on a chest X-ray.
Yeah.
I would always follow it up with something different.
Yeah. And what I found is that cancer can be really hard to detect on a chest x-ray. It's like always the benign nodules that are very easy to see. And cancers, because, the edges of them can be irregular and they're just a lot harder to see. So we've, tested chest x-rays against CTs, like, for example, in our larger lung cancer screening trials, and they just don't work as well.
Well, I think you did a good job of explaining why one modality, one type of thing might be used over another. Some of the soft tissue stuff better for MRI, and the PET scan, you can see stuff that's metabolically active. What are some of the terms that you've seen in your scans that are notoriously confusing?
Yeah, there are terms, I know not so much in mine, but I hear other people in the community talk about when something's stable. they're not quite sure how to interpret that as a positive. I mean, if they have metastatic disease everywhere, that's a good thing that things aren't moving along. But there are, other terms that are just not in our vocabulary, that are very medically, oriented. And if you don't have a background, you're Googling and then you're getting into that whole rabbit hole there. So when that report comes to us before our team has looked at it, it's something that we get a lot of anxiety about. Do we even want to open it? Because we really don't know how to interpret it, and how long will it be before we get the official, translation, let's say, from your physician on that. And so scanxiety, yeah, there's a lot that goes on between scans, during the scan, in the wait period, that patients are feeling. And so the sooner we can get those results from our actual, physicians who are following us, the better to reduce the anxiety level.
When you use the term stable, and I've had, communications with my patients, with friends who are asking some of the interpretation stuff, because you'll see variability. Like they'll measure it one scan to a different scan, and it can be really confusing because the numbers are different. So how is that stable? And we're going to go into that a little bit later, but I think that's a great example of something that, even as a provider, we're like, it's technically stable because it fits within certain ranges, but there's room for nuance.
Right. There's a lot of nuance, and then there's a lot of things that as patients we read into. Our imaginations can go wild. And then we reach out to another patient, and want that, I guess, validation that they think, okay, stable means good, and you're going to be okay, you're fine. And we still need that official, word from our doctors who are surveilling us.
So Heidi, you mentioned the scanxiety and the anxiety around waiting for your scans to result, going through the process of getting a scan, and all the ambiguity therein. Do you have any tips for anyone who is in the process of experiencing their own scanxiety, how they can manage that?
Yeah. So in the beginning, I really was letting lung cancer ruin my life. I would get a scan, get a good result, and then I would start to think, well, maybe something's starting to brew tomorrow. And by the time I'm waiting 90 days, we're going to have a wildfire right there. And then as I started to, continually do well and have more time between scans, I thought, what a waste of my time in my life to feel like that all the time. And maybe the best thing to do is, whether you have 6 weeks or 12 weeks between scans or 6 months, is to live your life to the fullest, enjoy it. And as it comes around a little closer, I still get it today, but it's usually about a week before I start to brew about the what ifs now. Things are going great. What if there's a hiccup and I have progression? What does that all mean? How long does it take to figure out treatment plan? And I'll have to take a pause, but I'll get through it. I see so many people in the community doing this with stage 4, with metastases to the brain. I used to think that it was all done for people at that point, and it's not. I mean, there's so much innovation that's happened. So live your life, enjoy your life, and then jump through the hoops you need to continue to do well and get treated.
One follow-up to that, a lot of people leverage social media or reach out to other people, but it's kind of like you're always in that emotional environment. How have you navigated being such a champion in social media, but also emotionally distancing yourself from this fear of progression?
Yeah, it's hard because I also become connected to people and I care about them. And so when we do have a loss, it's like, whoa, I do need to think about some self-care, take a step back, and then re-engage. I don't give myself a whole lot of time to step back because I know I could be missing other people who want to talk or be directed towards other resources to help. But I think we all learn to lean on each other a little bit, but it can become a bit toxic when you see a lot of negative and you want to identify with yourself too, like that could be me. But what are we doing to stay on top of it? And I think having a very open communication and relationship with your healthcare team is incredibly important. So they understand too where you are, what your triggers are. I think many of them are common. Long wait times between results are just not acceptable. I had to wait almost 4 weeks for a CT scan result 6 months ago. And everything ended up being okay in the end, but it was a lot of worry in between.
Well, and that fear of the unknown is what drives so much of our emotional hardship in any circumstance. With cancer, the stakes are so high. So the ambiguity around time is brutal.
It is brutal. It is. And does it have to be that way? Maybe in some places that's a staffing issue. And then we do the best we can and be appreciative of, getting the information when we get it. And then just dealing with things that you either know you have to worry about now, or maybe there's nothing to worry about now.
Yep.
And you move through it.
Well, and along those lines, Lauren, maybe you can speak to the probably $1 million question around all scans is, why do they take so long?
So I just want to say, and I know we are in the air, that 4 weeks is a shocking amount of time. I am really, really pretty blown away by that number. I think I just want to reflect on what Heidi has said, because it's so important for physicians, especially radiologists who are not always so connected with patients, that this is such a good reminder that there's somebody who's on the other side of that scan and they're waiting for our results, and what we say really matters and could make or ruin their entire day. And at the same time, I'll say, as a radiologist, I always try to remember that. I always try to do my best. When I read scans, I read it as if I'm reading a family member or a good friend or my own scan. And just remembering, I think, both sides is really important. In terms of, at our institution, our average turnover rate from time that you finish the scan, the time that we finalize that report, is about 24 hours. 4 weeks is, in my opinion, just too long, because we get follow-up scans 4 weeks later after someone's gotten treatment. I think 24 to 72 hours is very reasonable. I think that there are people who are, there are staffing constraints. Volumes can be variable at different institutions. One thing I will encourage everyone to do, I know radiologists aren't always sort of front and center and in front of mind, but I always encourage people to reach out to the radiologist, to reach out to the radiology department and say, hey, I'm, waiting for these results. I'm nervous. Do you think this could be expedited? And most of the time we'll get, one of the radiology assistants or someone will reach out to us and say, hey, can you expedite this scan? And I think, we do a pretty good job of that.
Yeah. So is it the situation where there's like a queue of scans, and then if there's something to stand out to say this scan is high priority, we're basing treatments around it. If that information is effectively conveyed, you might move the location of that scan.
I think it can happen. Absolutely. Look, if somebody's really nervous and I get a call about that, I don't, of course, I am so happy to accommodate that request. I think we're human, people are human, and tapping into the human side of medicine is really important. And everybody's at a different stage, and everybody's sort of dealing with this in their own way. And whatever we can do, whatever is within our power as radiologists to help them feel better, I think we have to do that. So I very much encourage that. I love talking to patients. I love answering questions. Another thing that I think is really important that I will sometimes delay the result, and you mentioned this earlier, is that a lot of people are getting their results right away released to their electronic health records. And if I read something and it's not good news, or I think it's concerning, and especially if it's after hours, I will reach out to the person's physician or NP or provider or whoever that might be and say, hey, look, you may want to reach out to your patient. I'm about to finalize this exam. That's not great news, because people need support. And I don't want somebody to read that report and not have the support or not have someone to answer their questions, right?
Yeah, I think that's common.
But not 4 weeks later. Let's be clear. Okay. Yeah.
But maybe we can have a little perspective as to what the radiologist's day is like. How many scans does the average person have in a day? I don't know.
Yeah, it depends. Look, the job is never done. It varies by institution. We scan after hours, very late, sometimes until 8, 9 p.m. And we scan on weekends. And that's to help our patients find a time that works for them to get scanned. If they work, if they have other priorities, we want to accommodate people. I think that's great. So, you can read dozens of CTs, dozens of x-rays every day, MRIs, PET scans. Yeah, the list, there's always a list, right? But I think it's important to accommodate people when we can do that.
Speaking of scans, we've got some here, IV scans here. And I thought it might be nice that we have, a trained radiologist who can come here and go through that with us. Because I think a lot of people, nowadays we get our scans directly to the patient. And I think there are a lot of people out there who get their scan, like that. I'm not used to reading these. I don't know. And the way that we as providers put information in, and I'm certainly guilty of this sometimes too, is a lot of it is with the intention of just going through kind of billing codes and making sure the system functions. And we're not always the greatest at thinking of the patient who's going to be reading this. So I want to make sure we go through what a lot of this stuff means. And some areas where if you're the patient reading it for the first time, maybe take this bit with a grain of salt. I think that'll be hopefully helpful for those listening and watching along.
Yeah, absolutely. So Heidi, should we read it together? So we have Heidi's CT for chest, abdomen, and pelvis, the report, and we also have a PET scan report, PET CT report. So
this was back in 2018. So maybe some language has even changed and evolved in reporting since that.
Yeah, and I can kind of just go through the skeleton of a report just maybe to start. So typically we get a clinical history. This is whatever the ordering clinician usually has put in. Clinical history is actually really important because if someone is coming in with a cough for a week versus a cough for 10 months, right, that's going to change my differential diagnosis. I think clinical history is really important to kind of guide the radiologist in helping form an informed opinion of what's going on, that sort of thing. And then usually the next section would be the technique. This is, the type of scan you're getting. Is it a CT scan? Is it an MRI? Are we giving dye or like contrast that we're injecting? Maybe it's done with and without. And then the next section would be comparison. So radiologist's best friend, but hopefully not their only friend, would be comparison scans. Prior scans are so important because if I'm looking at your lungs and I'm finding a nodule, maybe that nodule has been there for 2 years or 3 years or even a year, and that will change my management strategy or my recommendations. So if you don't have prior scans, that's okay, but prior scans are always really helpful. And a lot of times we'll ask, you guys to bring in prior reports and that sort of thing. We can always make an addendum and compare. And then typically the next section would be the findings section. This is where the radiologist, goes through everything that they see. And then there's the impression. And this is really the takeaway. So based on what we're seeing, everything we described in the findings section, this is where we form an opinion about what we think is going on. And we give recommendations about next steps. So in your report, and I'm sure you've read this many, many times.
And let Pierre read it.
Yeah. So, I can kind of just go to the findings section where the person describes what they found in your lungs, right? Which is this 2.5 centimeter lobulated, somewhat spiculated pulmonary nodule on the left upper lobe. So, they're kind of describing what this looks like. They're describing features of it because that's what we use as radiologists to decide if we think that something is benign, if we think it's suspicious and it might be cancer. And so these descriptions of lobulated, spiculated, those are kind of buzzwords that we use for findings that are more suspicious. And then they kind of go through your lymph nodes and they talk about, some enlarged lymph nodes measuring up to 11 millimeter. Typically, we measure lymph nodes in the shortest axis. If you think about it, it's like a little bean, we measure it in the shortest axis. And over 10 millimeter for the most part is going to be enlarged, or 10 millimeter or more. And, so then they're kind of going through everything. And in the impression, they mention the nodule, right? And they say that that plus the lymph nodes are suspicious, right? And he says, he uses the word bronchogenic carcinoma. This was back, he said, 7 years ago. So our terminology has changed. What he would probably say now is, adenocarcinoma or primary lung cancer. And then he's saying that the mediastinal lymph nodes are enlarged. That's known as lymphadenopathy. And so he's recommending then, that you need further workup. Is that right?
Yes.
Yeah.
So a PET scan followed.
PET scan followed. So PET scans are very helpful. They can tell us something if something is metabolically active, like I said before. So you got an FDG PET, so you're given the sugar-like substance. One thing to remember, like I said, it's not everything that lights up is going to be cancer, pneumonia, right? Things that are infectious, things that are inflammatory, things that are just working, like your heart and your muscles, those things light up. But, what we found is that he called it a mass. Technically, it's a nodule, but it's below 3 centimeters, but we'll talk about that later. And he said that it did light up. So we call this, there are different names for it, but he's saying there's FDG activity, or it's FDG avid, or there's uptake, and that your lymph nodes were also FDG avid. And so this is suspicious, because he didn't think it looked like pneumonia. He didn't think it looked like inflammation. He said that based on the findings, it was suspicious for lung cancer, and then recommended a biopsy.
Right. And that was the next step, into the frenzy of feeling anxious and feeling totally blindsided again, that this was something that was never on my radar. Again, my take on prevention for other cancers has been screenings, early detection, catch things early, and the prevention for lung cancer had never even crossed my mind, because I didn't know about lung cancer screening. I would have advocated to have that, because I've always been proactive in my health, but I wouldn't have been eligible. So how did this all happen? And how did it happen so quickly once the first CT was taken for investigating a different health issue, and then evolved to, I have late stage lung cancer? Just know that your patients' heads are literally spinning at that point, and anything you say, as gentle as it is just blah, blah, blah. We don't hear anything else at that point. So I don't know how one approaches that. Generally, it's helpful to have another person with you when you're getting all of this information. But most of us are clicking on a phone now. I mean, I didn't have this 7 years ago. So, and then where are you seeing this for the first time? Are you at a stoplight in your car? What are people's habits? I mean, I don't know.
Yeah.
So lots to think about when these results are just automatically sent to patients and you're writing those reports. I understand the patient's right to want to know quickly, but if you don't have all the information and to interpret that, it's very anxiety provoking.
Well, and in the scans, we use a lot of terminology around kind of different risk profiles for a thing we see. And Lauren, I'm wondering if you could speak a little bit. You're using the terminology suspicious. And we see in different scans things that are low likelihood of being cancers. You might say you still follow up, but then things that you say suspicious, we don't say it is cancer. Can you speak a little bit to the perspective from the radiologist on the terms you use based on how risky something is for being a cancer?
Yeah, I think the things that I'm really looking for are clues to see how long something has been there, right? So what is this, how big is the lesion? So typically things that are larger tend to be more suspicious. Things that are smaller tend to be benign more often, right? I mean, of course, all cancers start from one cell, but there's something that we call doubling time, and lung cancers, or really any cancers, tend to grow at a faster rate than things that are benign. Things that are benign can absolutely grow. We see this, and that can be totally normal. It's just that typically what we call this volume doubling time for lung cancer would be less than 400 days. And so, if you think about that, it's like a little over a year, right? So things like that, is this lesion or nodule growing? And what do the margins look like? Is this something that's really well circumscribed, that has smooth borders, or are the borders kind of jagged, meaning maybe it's invading the adjacent lung, or, is it actually going into an adjacent structure? Is it causing an obstruction? Like, is it blocking your airway, or is it blocking a blood vessel? Those sorts of things. Signs of something that is more aggressive, right? Then that kind of raises some alarm bells. If I see that this lesion is causing, it's tugging at different parts of the lung, we call this architectural distortion. And that tells me a couple things. One, that this is something that's kind of more aggressive, but also that's probably been there for a while, right? This is not something that popped up yesterday. And that's why I also say clinical history is really important, because if I know somebody has had a cough for 10 months, this is probably not going to be pneumonia. I always try to give things a chance not to be cancer, because here's the thing. If I say, follow this up in 4 weeks, right? You really don't know. You're like, this could be pneumonia. And so you don't want to scare everyone and say can't exclude neoplasm, because then everybody's just sitting there for 4 weeks worried that this is actually cancer. And if it isn't cancer and it goes away, then great. And if it is, 4 weeks is not going to make a difference. It just, for a large majority of cases, it's just not. And then at least you've given that person, some peace of mind for at least 4 weeks. And then you can hit the ground running with, treatment options and that sort of thing.
You use the term there, can't exclude neoplasm.
Yeah.
Being like, we can't say it's not cancer.
Yeah.
And I think we do that a lot in medicine in general, not just radiology.
Yeah.
If you're not 100% sure it's not the scary thing, we have to mention that. And I think a lot of people hear that or read that now, and they say, I might have cancer. Can you speak a little bit to maybe the percentage of people that have something that you can't say it's not cancer definitively? Like, out of that pool, what percentage of that tends to be cancer? What percentage tends not to be cancer?
Let me just kind of take a step back for your audience and explain what a nodule even is. So I explain nodules like freckles or moles on the skin, right? Everybody has them. I have a lot. Most of them are benign. But it's a good idea, especially if you have risk factors like a smoking history or family history. It's a good idea to just watch them, make sure they don't change, make sure they don't grow. So I would say, and then you can kind of think about, okay, there are solid nodules, meaning like, I can't see through this, right? It is completely opaque. And there are what we call ground glass nodules. Ground glass is like the frosted glass window, or like the glass you find on the beach. We can see through them. And so we can see the normal lung architecture through these. And a lot of these nodules that are not solid, that are ground glass, they grow very, very, very slowly. Just like moles, they can be precancerous. So those tend to take a very long time to develop into lung cancer. And we typically just follow those, whether it's a year or every couple of years. The solid nodules, I would say if it's something that looks like pneumonia, and I think it's pneumonia, it usually is. And there are very few times, I can't give you an actual percentage of, how many times I call something pneumonia and ends up being cancer or vice versa. But what I can tell you for sure is that if I am recommending, especially on a first scan, recommending a PET CT or a biopsy, I am over 99% sure that this is probably cancer, right? And here's the thing, is like, if I don't know as a radiologist, and I'm like, this really might be pneumonia, but there's just something about it, I will reach out to the physician and I'll send them an email, or I'll send them a chat or a text or a call if I have their number, and say, hey, this could be pneumonia, but I am a little worried about it. So let's just make sure we follow this up in 4 weeks. And if it's still there, this needs to be biopsied, or this needs a PET, right? And just to make sure that this doesn't fall by the wayside and this person gets the care that they need.
You have a vernacular, a certain language that you use when something's really scary for being cancer, and you're going to push aggressively.
Yeah.
PET scan, biopsy. Then there are these things that are, could be, probably not, let's monitor it. And then there are things that are not cancer.
Right.
And, we had a previous episode with Alex Dragonich, a pulmonologist, who, most of the pulmonary nodules they see are not cancer. And there are findings of nodules or things that can occur within the body that are these strong suggestive things of cancer, and we don't want to ignore those.
Right.
But it's nice to hear the different nomenclature that someone might see in their scan, how worried should I be? And it seems to me that the radiologist is probably going to let you know how worried to be, by and large, with the recommendations that they have. One thing I wanted to jump into a little bit more is, because this is something that I contribute to, is the term indication on the scan. Where does that come from?
Good question. So it can come sometimes just from being automatically pulled out of the patient's chart. Most of the time, this is something that whoever ordered the scan, they enter that in. And you hope it's correct, right? We hope as radiologists it's correct. I had an example of a case a couple weeks ago where it said this patient had a cough for, I believe they had said 10 days. And this finding just looked really suspicious. I was like, wow, this could be pneumonia, but it has a lot of really scary features. And let me just give the physician a call. And sure enough, we had actually meant 10 months. And I was like, okay, got it. Yeah, this is very concerning. Like, this person needs a biopsy. And again, it's very rare for me because if I'm a patient and someone sticks a needle in my lung and this isn't cancer, like, I will know that I'm unhappy, so I try to put myself in that position too. And so I was like, okay, yeah. And that's why the clinical history is so important. Does somebody have an inflammatory disorder like a connective tissue disease or sarcoidosis or something? Because there are a lot of cancer mimics out there. And so the more information that we have as radiologists, the more helpful we can be. I think it's really important that a radiologist, I try to narrow my differential down to at least 2 or 3 things, right? If you get a whole sort of list, a laundry list of things that it could be, you're really not being that helpful. And so I think our job is to say, with the information that I have, the clinical history, the imaging findings, here's what I think it is, and these are the top 2 or 3. And as more information comes along, like for that particular example that I gave, I went back, I made an addendum. I said, based on this, I think that this person needs a biopsy. And that was that. They got a biopsy 3 or 4 days later. And sure enough, it was cancer.
So I want to reassure people who are looking at their scan and they look at that indication is not a diagnosis.
It is not.
So I want to reassure anyone who's looking at that, and that is something I would definitely take with a grain of salt.
Yeah, a lot of times people are trying to say evaluate for cancer or evaluate for pneumonia, and they just write pneumonia or cancer. And so, like, as radiologists, I'm like, okay, do they already know maybe that they have something, or it's just our job to tease that out, I guess. But that's why communication is so key.
Yeah, I've definitely in the past, mistakes to learn from, put in evaluate cancer, and then the person is, when was I diagnosed with cancer? Right. And you're like, okay, I can see now.
It's like,
conversations start.
Yeah, it's a buzzword. I mean, it is for sure.
Yeah. And so we were talking a lot about the interpretations of the scans and we're going through, but Heidi, you've had these scans done yourself. Can you explain what the process is going into the facility, what it's like in contrast? Like, take us through getting a scan.
Yeah, so you're given information beforehand on how to prepare for the scan if you need any preparation, or they tell you if there is not. You go in, you check in, you fill out a form, I guess, giving, not permission, but you're declaring that, no, I haven't had an allergic reaction to this before. And then you're taken back. And in my case, it's not always a whole lot of fun trying to find a vein after I've been through some chemo and radiation and immunotherapy for over a year. So my veins, I never had a port. So I always let them know that in a note beforehand. So they're prepared and they know exactly where to go with a warm compress. And then we get that rolling. And when you're going through the CT scan, it really doesn't take very long. You listen to an instruction that tells you to, breathe normally or take a breath and hold and then let it go. And you go through this if you're having, whether your chest, abdomen, and pelvis are all being scanned, it may take a little bit longer for each body section. And then after that, they say they're injecting the dye now. So you've been prepped for it, but nothing's been put through, but a little bit of saline at first. And then when that injection comes through of the iodine, the contrast dye, you feel a sense of warmth going through your body from like head to toe. And then it just kind of stops. And then they, come in, maybe you're in that state for maybe a couple minutes. And then they, unhook you they take you out of the tube and they unhook you from the IV, and you're on your way, and then you wait. So the scan itself, has become very routine for me. I know the process. I try to facilitate the process, knowing what my veins are like, and then starts that wait. And so that's always something to think about. What are you going to do after this? I mean, have a plan. It's like, okay, I'm going to go for a walk now, or I'm definitely going to flush with fluids, drink lots of water, but maybe I'm going to do something fun, and to try to, make the time go by without watching the clock. Live, just live your life.
Yeah.
When you had mentioned managing scanxiety and how do you cope with this ambiguity to stay active and to keep doing things, do you specifically schedule activities around those high anxiety times to keep you busy?
I do. I do. So for me, exercise has always been a great outlet. And, once I drank enough water and I start flushing some of this out, it's like, okay, I'm going to work out now. Or I'm going to hang out with, a good friend, or have coffee, or build ribbons. That's another outlet. There's always some of that to do, which has actually been pretty key in dealing with a lot of the anger, is the cutting, and more of the just, okay, I'm waiting, I'm painting, labeling and signing. So there's been little, symbols of how I deal with my anxiety within my project itself that helps me. But it's not easy. It's a roller coaster. There's no, correct recipe. I think everybody's going to have their own coping mechanisms, and none of it should be ever dismissed. And sometimes that is, I think, hard for the people around us to understand that we just need a timeout, or we need to just vent at full blast, and there's a lot in between there. And to try to give us a little bit of grace, knowing that this is a disease that even if you're no evidence of disease, you're never really done. You're going to be surveilled, and this is going to be part of your life for the rest of your life. And to accept that, that we are who we are. We've been changed forever by the diagnosis, and we're coping the best we can.
Yeah. And, thank you again for having the support community that you've helped foster to help all these people who are going through the same stuff. And a lot of it is so much of a cancer patient's life is around these scans. Like, it's so central to how they feel. And, we both have friends in the lung cancer community, and scans are pretty common. You're getting them every couple months, sometimes as early as 6 weeks or something like that. So the second you're done with one, you're anxious about the next one, which you spoke to earlier. It's like, could the growth be starting right now?
Right.
And no one's going to be able to say for certain no, so it's tough. There's a lot of emotional energy around the scan.
What I see a lot in the community is they do rely on each other on social media. People will announce a bit of scan coming up, I'm worried, and people will then give a lot of support to them, prayers, positive thoughts, whatever it is that person is seeking, and they can find it on social media. I used to do that in the beginning, and then I kind of retreated from it. I thought, okay, I want to just be able to be supportive to other people. I don't want them to, necessarily worry about me. I'm going to handle my own. And also for family and friends that are connected to my social media, I don't want to drag them through a time full of anxiety unless something pops up, and then now we know, okay, we know what we have to deal with. Otherwise, it's just everyone else is worrying until 4 weeks, to get that scan. I was like, never again. No. Oh God, I really appreciate about this conversation is I never knew you could reach out to your radiologist. I thought you could just reach out, but reach out to your navigator or your team, and that they're going to advocate for you on is this red? Is it even in the line yet? I mean, where is it? Yeah. And to know that you can reach out to your radiologist and let them know is valuable information. So thank you.
Yeah, of course. Yes. And you can reach out to the rest of your oncology team too. Say, hey, because they may not know that scan that they've been waiting for hasn't come back yet. They have a full panel of people. They saw a lot of people that day. There are a lot of things in the air, and they might be waiting for it, but if it doesn't arrive, they may not trigger in their mind, oh, wait a minute, this should have been here by now. So nudging your care team to say, hey, this scan should have been here.
Yeah.
I think will be helpful too.
Yeah, I think letting people know that you are having anxiety over this or you're losing sleep is important. I know some people get just so angry and lash out, and we're all on the same team here. And I think, our radiologists, our thoracic oncologists, our teams in general truly do care about us. And then it's hard to get slammed with some hard words. But if they know that, you're genuinely, you're someone they care about. And when they know that you are concerned that you haven't heard, imaginations do go wild. It's like one of the things that ran through my mind when I had this 4-week wait was maybe it's so bad they're not ready to tell me and they're trying to figure this out, which I know doesn't make any rational sense, but you're not in that frame of mind, right? Because you know that these results just automatically get, released. So that's what you're dealing with. That's just on the other side.
And along those lines, when you do get scans back and there are changes, like scans are pretty much always dynamic if you have something there. So it could be a tumor that was treated in some way, chemotherapy with radiation, and it shrunk down a little bit, but didn't go away. Sometimes with the therapies we give, you run immunotherapy where things can even look larger on the scan. We don't call that growth, on immunotherapy uniquely. But to say there's a lot of nuance around scan to scan and how you interpret it. Whereas if you're not trained in this stuff, it's really hard to know what's going on. So Lauren, I guess my question for you is, when you're evaluating changes from scan to scan, how much growth is too much growth? When do we call this progression?
That's a good question. I think, look, everybody's different. So I may measure something slightly different than my colleague did, right? And that's why it's important, the findings are the findings and our measurements may be slightly different, but we have to be very explicit as to whether we think that something has progressed, whether the disease is stable, whether there's recurrence, whether there's metastasis. We typically use, we say that a 20% change, whether that's an increase, which would be a growth, or 20% decrease. That's typically the percentage of change that we would use to be a meaningful change. But as you said, of course, we have to know as radiologists if these patients are on immunotherapy, because this could be pseudoprogression, right? Especially if this is the first scan after they got immunotherapy. So it's really important that everybody on your team is an expert, that we all, to the best of our ability, can evaluate this and tell you and our impression, right? That's what the impression is for, to say how we think this has changed, if it's changed, and what we think the recommendation would be, right?
Yeah. And, there is variability. There's variability from person to person. When you're in the scanner, your body can just be slightly, the orientation can be a little bit different. Mm-hmm. And I've had calls with friends and patients who will say, oh, it says stable, but it's grown by 3 millimeters. So, well, it was 30, and if you have a large, there's not that big, but if you have a large tumor and things are changing a little bit, you can just get a different measurement and it could be the exact same.
You're absolutely right. I mean, that's why it's so important to look at all three planes, right? So you're scanned like this, right? The scanner goes through your body, but then we also scan, we can also look at images like this. Then we also look at images like this. So we have 3 planes, and it's really important to look at whatever you're evaluating in 3 different planes, and then also look for other signs, right? Like there are signs. If someone has gotten radiotherapy, I can look for things like, is there new blockage of an airway in this area? Or maybe the margins just look a little bit more bulgy. That is not a technical term, but that is a patient-friendly term, I hope. So, is there a more contour bulge? Is something obstructed in a way that it wasn't before? Those sorts of changes can give us clues as to whether there is actually a meaningful change. Maybe, there is recurrence or there is growth or that sort of thing. But it's important. And when I see these things, I always contact the oncologist. I, make sure that I know exactly what treatment they're on and when they finish their course, that sort of thing, especially because radiation changes can really occur over a very long period of time, right? And so you want to understand, as a radiologist, I need to know what that normal evolution looks like, and that it could be okay to actually see what looks like growth, and that just be kind of a normal evolution of radiation change.
Yeah, I could see that if someone had radiation, the tumor shrunk down, and then you see some changes that are maybe not huge, but it's in the wrong direction. It's growing. That could be really concerning if you don't know these contexts that,
Right.
one, you're on immunotherapy, two, you just got radiation.
Right.
So the 4 millimeter growth, change in one direction, we're not that excited about. But you would know that if the scan just comes to you and you have your visit in a week and a half, which is very common. I'm curious, Heidi, have you yourself or through patients in the community, have you heard of situations where the radiology read and the oncology team disagreed?
Yeah. Sometimes you see, or again, it's all secondhand. It's by what the patient reports. And generally I see it on social media that I was so worried when I looked at this, and then, my doctor explained that everything's great. Everything's just great. And so I don't know if those, two disciplines are disagreeing, but that's the interpretation. That's more what I see. I have seen things down the road where people are expressing that there was progression back a year and a half ago, and now they see that, there was no note about that when they go back and look at the scan, and somebody had missed something. And so now someone's having to deal with, pretty serious progression. I don't see that a lot, but I've seen it a few times, and those people become very vocal about it because, it's scary. And then they want their community to, I guess, know questions to ask their own team.
Yeah, this is one I think of the biggest challenges of being in radiology and being a radiologist is all of your work is seen through the retrospectoscope. It's like how that is, you can always look back in time and say, oh, was that thing actually there? Now, I don't think people have a full understanding until they're in medicine and they look at a lot of scans, that there's a lot of stuff in scans. Can you speak to how much stuff in a given scan might you not mention just because of the natural noise that's in the human body?
Yeah, a lot. I would say, I love thoracic imaging because it's like there are only a few organs in there. If you're reading, abdomen, pelvis, right? If you're a body radiologist, that's what we call them. There are a whole lot more organs. But, in general, of course, when we're reading lung cancer PETs, I'm reading the entire head to toe scan. There's a lot in there. I typically find a balance between mentioning things, especially in patients who are dealing with a cancer diagnosis. I'm mentioning things that I think could be clinically important. This could be related to the cancer. It could also be something like coronary artery calcification. So, plaque that is in your heart vessels, because as Heidi can tell you, that can be important later on when you have gotten treatment. And then this can lead to a heart attack or a stroke or that sort of thing. And so it's important to not overwhelm people and find a balance. I mentioned things that I want people, especially the next radiologist, to pay attention to. And then I mentioned things that I think the oncologist should pay attention to, or the care team should pay attention to. So, I think it depends on the scan, but I try to go for the more salient findings.
Yeah. And within there, it's a judgment call as to what small things within the lungs. In your lungs, you inhale stuff and you get little nodules. You get tiny little punctate things on the scan that could that one day be a cancer? The likelihood's no, but that's not zero. And if you look back in time, there was something there. That happens all the time.
It does.
And I don't, I can understand the patient perspective.
Yeah.
To say, how come you didn't see it? But, I'm on the provider perspective, looking at the scans, and I have a lot of sympathy, I think, for the radiologists who you have to make good. This thing, your scan would be like 10 pages long if you listed every little thing that you see because of the just normal human variations. So it's hard. It's hard. It's a hard job. It's hard to, have everything accurate, knowing going forward without scaring someone that they have 300, little nodules. So that's tough. I wanted to make sure we had just an appreciation that there is judgment call in radiology. That's why you need to be a radiologist to do it. It's
Yeah, we're human, we're not perfect. I think something that's really important is having humility and being able to admit when you're wrong and learning from that, because people make mistakes. But if you're not learning from it and you're kind of doing the same thing or you're rushing through something, it's tough. I find a lot of times I'll find these teeny tiny nodules and you're like, honestly, these probably are not mets, or you just don't know. Maybe it's the first scan. And so you say, okay, let's just get a 3-month follow-up. And I usually say they're probably just impacted airways or they're benign pulmonary lymph nodes. Just get a scan in 3 months. And then if they are metastases, you would know usually within 3 months. And if they're stable, then that's a good sign, right? And then the patient will continue to get follow-ups. But I just think it's important for radiologists to be able to admit when they're wrong. And, because I imagine, look, I've been a patient too. And I think that humility and just an honest conversation go a really long way.
Well, I think this is a really important conversation because I think, as the patient perspective, I've been able to give the message, and many patients have, is that there's a human on the other side reading that report who doesn't have the background to understand a lot of these words and nuances. But it goes this way too. You're a human. You're not a robot that just bounces. Well, I don't know that people understand that, that you're specifically trained to read these images that when we look at, we have no idea what you're looking at. I mean, sometimes like my scan was obvious, was like, oh my gosh, what is that in my chest? But for the most part, we don't see these nuances. And here you're extrapolating that visual to then combine it with what's in our clinical histories to get a sense of what is this, and then communicate that back in a very, I wouldn't say strategic, that's not the word I'm looking for, but a uniform way that you present.
Yeah,
Right, an intentional way to get that point across. And that's what we see. But we need to understand that that's generated from a human with feelings, with a lot of training, expertise to know how to document this. And then it's up to our teams to then translate that information to us in a timely manner. So
this is why conversations are so important. Like, I love that we're able to come together and have these conversations, and it just remembers, and it makes medicine human. It reminds us that we are all human and we're all trying the best that we can. Hopefully, right?
Yeah, and imagine the person doing their best is wrong 5% of the time. For someone who works in cancer, those are a tough 5%. We care a lot, but the stakes are really high. And if the thing that's in the liver, doesn't really look like anything, but let's say you had something we thought might be cancer there, or something we later found out, your care would have been so different. Mm-hmm. So yeah, the stakes are really high. People are doing their best, and what we're doing is hard. Particularly the radiologist job is a very hard job. Not only to convey all this stuff in a way that makes sense and isn't scaring people, but getting appropriate concerns and saying, we can't rule out cancer. I don't want to scare you. It's probably not, but if it is, you need to know, they're balancing a lot of things, and the scan has to be accurate.
Thanks, Kata.
Thank you.
Yeah, no, I think this is very important to empower all sides of this, because we all are on the same team. We have the best outcomes for the patient, and patients need to understand that they can advocate for themselves too.
Yes.
And it's probably easier now than ever when you do have your medical portals to send an email, just say, I'm really worried about this. I haven't heard back. Or I read this and this is really scaring me. Can someone please, get back to me and explain what this means? Because there is so much hope these days. And if we're surveilled like this, we are hopefully or most likely catching progression or something new quickly, whereas earlier, where we have a chance for a better outcome with whatever that is, if it's progression or a new primary or some other medical condition that you need to be on top of. So you give us a really good window into our current state in that moment. And if further steps need to be taken, or we just stay on our path, then I'll see you again in 3 months, and we'll keep looking through that window.
Thank you. And this is actually why I love when patients call me, because it's so much easier sometimes to just have that conversation. Just say, honestly, I don't think these are anything. Or, yeah, if you were my mom, if you were my sister, just get a scan in 3 months. My suspicion is pretty low, but just make sure. And then you're done, then and you have a better answer. You can't convey that all the time in a report. But if we can just kind of have a talk and be able to level with each other, it's such a meaningful conversation, and both sides, I think, come back with a better understanding of what the other person wants and what the other person's intention is.
One thing I think would be so cool, and we're probably at a place where we might be able to do this, you have the report and you have your impression, and that is usually designed to be provided to the provider. But there could be an audio file from the radiologist that's 10 seconds long that gives and I can hear your tone, and I can tell how worried you are, and say, yeah, I see some things in here. The overall looks stable to me. I'm actually not too worried about it.
Yeah, and there are definitely folks out there who are doing that. We were doing that actually for a period of time. We also did some video visits. So we would go through patient scans with them, especially it could be something that they had a question about. A lot of these patients needed a follow-up. And so I do think just having that conversation is helpful. Look, not everybody wants to talk to the radiologist. And some people, they just want to know, they want to know the bare minimum, or what do I have to do next? And so I also think understanding how much do people want to know. But yeah, I love this. And I think radiologists should be available in this way to people, right? I mean, a lot of people don't even know what radiologists are, or I have a lot of friends who mix up radiation oncologists and radiologists, right? Yeah. Even in healthcare. So I think that we can all kind of do a better job as radiologists at getting out there and talking to patients.
Well, Heidi, from the patient community perspective, what do you think are some ways we can make the information from scans more understandable to the traditional patient?
I think you have to use the words that you use in the reports, because it's the standard, right? And it's important not to have too much nuanced in there. But I don't know if there's a way, everybody's overworked. How do you do this? Is there a way for someone within your, a radiologist team to be able to, I don't know, send out, in addition or next to it, here it is in layman's terms for you, or that? Yeah, but I know everybody's overworked and, understaffed. And is that something that could be put into GPT chat? I don't know, to put in, or do patients do that on their own? But many don't even know what that is. So if there would be a way to kind of translate it before you actually hear from your team, if there would be a lag. You seem to have you do have a very efficient system, where you are. And so people aren't having to wait as long, but I don't know that is even average across the country, if anyone is, up to that.
Yes, now I'm curious.
Yeah, I know.
Because I had never heard 4 weeks.
Yeah, that was the first time it happened. I think as the evolution of being a lung cancer patient for 7 years now, in the beginning, the wait was about 48 hours. Yeah. And then a couple of years ago, it was literally by the time I get home from the scan, I had a result, on the same day. And then this last one was just, wow, close to 4 weeks. It was a long time.
Yeah.
And then I worried. I went back to the, mantra of, wow, how do I know my scan still looks like this?
Right.
Maybe there's something else. And going through a negative mindset, which is never a good thing.
Although at that point, it's somewhat of a realistic, 4 weeks is too long.
No, that was never too long.
Yeah. But, I think I've definitely learned a lot about the ins and outs of managing the scanxiety and what goes into some of those delays with people or systems being under-resourced, I guess.
Yeah, and I think what's helped me get to that coping mechanism that works for me, trying to live it out or do things I enjoy, it didn't just happen to me in an epiphany. It was with the help of the social worker within the oncology team. And so remember, you have these resources, as patients, that they can help shepherd you through these really rough times. I also will actually set up an appointment for the day after a scan. And, I'm venting there too. So, and intermingling the self-care as well. So.
Well, and speaking of leveraging that anxiety for something productive, this is a good segue into the White Ribbon Project. Maybe you could tell those listening what it is if they don't already know, and where they can find more information.
Yeah, so the White Ribbon Project is a lung cancer initiative started by my husband and myself out of our frustration that there really wasn't much awareness and education about lung cancer along the whole spectrum of lung cancer, from screening to research funding through treatment options and survivorship. And so my husband constructed a big white ribbon out of wood for me that I put on my front door to at least educate my neighborhood during the pandemic that I had lung cancer. I wasn't ashamed of it, and we need to talk about it. Before we knew it, this went viral, and we have now created thousands and thousands of ribbons that are across not only this country, but in 36 other countries, getting people to understand that they are definitely not alone. We are here for each other, and we need to talk about this disease to educate people with the fact, and I have subject matter experts sitting next to me, that anyone with lungs can get lung cancer. No one deserves it. And we need to do better for ourselves and our community by talking about this.
And where should people go to learn more?
So they could go to www.thewhiteribonproject.org to find our website. We have community calls the third Saturday of every month, and you can find the link on our website as well. We also have social media platforms on Facebook and Instagram at the White Ribbon Project. And then on Twitter, and we are VWRP4LC.
And then, hopefully we raise more awareness for lung cancer. And for those who are screening eligible, Lauren, maybe you could tell us a little bit about your project.
Yeah. So before I do, I just want to say thank you for inviting us into your home and showing us where the White Ribbon Project began. It was very cool. I'm just beyond impressed with the work that you've done. So a part of the research, or I guess the work that I've done around improving the uptake of lung cancer screening, my focus initially was in primary care settings, because primary care providers are such an integral part of cancer prevention and control. They've been great in terms of tobacco cessation. I mean, they have a relationship with their patients that, is very special, I think, a lot of times. So, I felt like these are people we can really engage, and we can try to engage their patients. And one of the resources that I created is a website called lungcheck.org. So, the website is free. It's easy to navigate. What we wanted to do was create something that had more positive messaging, because lung cancer is not a death sentence anymore, right? I mean, I think that's everybody remembers. And I remember when my grandma was diagnosed with lung cancer and I was around 10 years old. She died within a year of her diagnosis. She was diagnosed with stage 4. She really suffered a lot. And we all know somebody with that story, right? And it's so different now, because when she died, actually, I think ILCAP, which was the first lung screening study, was just starting to enroll people in their trial. And so now we see that we've come so much further, 30 years later. And lung cancer is not a death sentence. I think that we don't need to lead with, if lung cancer is the number one cause of cancer-related death, can we lead with, but it doesn't have to be, because, if we catch lung cancer early through screening, it's more amenable to treatment and it is potentially curable. And so I just wanted to create something that was transparent, that was optimistic, that had inclusive and non-stigmatizing imagery and content, and was just easy to read through, just have all the high yield information. So there's a provider page and a patient page. And we really talk to patients, providers, front desk staff, quality improvement personnel, navigators, like anybody who is a part of this process, this lung cancer screening process. We wanted their input. And that informed our website. So I think we've created something special. I hope we have. And, I love feedback. We've gotten a lot of feedback on different colors and different things. And so I always welcome that, because we're always trying to improve the resource. But please check it out. So thanks.
And one last time, the website link.
Yes, lungcheck. So lungcheck.org.
Yeah. And I think maybe we'll end on one piece of advice that you both will give. We'll start with Heidi. For someone who has a new scan, as a concerning finding, what would you tell them?
I just want people to remember that there is hope along the spectrum of lung cancer now. There might be other hurdles to get over, but there are so many people on this team now and new innovations. Things are coming out every day. So even if there were progression, I think there's going to be something else in the toolbox to help you and a huge community of support for you. There's hope.
Yeah, and I'll extend that to other cancers too. We're all in the lung cancer sphere by and large, but the changes and the improvements to research are really ubiquitous throughout cancers. So I think if there's a concern anywhere in the body for a cancer, even things that were a couple years ago really, really morbid, things like pancreatic cancer, which are really hard to manage. There's hope even in those spheres too. So it's a different world. I totally agree. And Lauren, what's one piece of advice you would give for our listeners?
I think I will double down on something that Heidi said earlier, which is just that to remember we're all on the same team and that we all want the same goal. And I think this goes for both providers and also patients. It's so important that we get to know each other and we build this community. I was fortunate enough to participate for the first time in your community call, the White Room Project community call. And it's such an important experience to go outside of yourself as a physician and hear not what just your colleagues are doing, but what survivors are doing, or someone who's carrying a new diagnosis, or their family member, because that's how you really grow and that's how you evolve. And that's how we can work together as a team to continue to build the hope that you have built and shouted from the rooftops with this amazing white ribbon symbol that you've created.
Yeah, it's all about communicating, working together for that same goal of better outcomes for all of us, saving lives. Yeah, we can do this.
All right. Well, that's this week's episode of Cracking Cancer. And for us, you can like, subscribe, and visit crackingcancer.org. All right. Thanks, everyone.
Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.